All right, guys, let's get to this. We're getting close to the end of this term. We're going to start on the neck. Let's do it. I'm going to stop video on me. Let's focus on the notes. There's very few notes today, a lot more concepts and looking at the pictures. So at the neck, just a continuation up that spine as we work our way up. So a key point I want to bring up is really when we get to the junction between C1 and C2. So that's where we have our atlas and axis. We talked about this back in the overall spinal lecture. And this joint is very important. This is where our motion for rotation comes from for our cervical spine. This is called the atlanto-occipital joint. Like I said, 50% of your rotation comes from this. So before I scroll over and show you the joint, do you remember the key element of the joint? And hopefully you're thinking the dens. All right, let's go check it out. So over here, this is C1, C2, the atlanto-occipital joint. So on top, right here, we have our atlas, axis. And right here is that dens. It projects up through the atlas. And this is where rotation occurs. Rotation occurs by the atlas moving around the dens. And that's where 50% of your motion comes from. Now, if you haven't taken a good look at the pictures and tried to read into the arthrokinematics of how the facet joints and their orientation plays into motion, you need to do that. So when we look at this whole cervical spine, yes, motion is coming from all those vertebrae, but again, 50% of that motion is coming from the dens and the atlas, okay? Now, with this itself, though, we are subjected to potential subluxations. So we need to be very, very aware of this. So there are three major patient types that could have, or pretty much any treatment to the cervical spine might be contraindicated, or a manual treatment, depending on what it is. So things to look out for: RA, rheumatoid arthritis. Remember, rheumatoid arthritis from your anatomy class is when your body is attacking the joint structures themselves. So it's going to weaken the joint capsule and the ligaments around holding the dens in place. The next is Down syndrome. Patients with Down syndrome typically are hyper flexible anyway, so we need to be aware of that. And then, of course, if there's been trauma in the area, which would always be a contraindication for doing certain types of treatment anyway. So, oops, sorry, didn't mean to go that way. So that's a major thing to think about. A second thing we're looking at here is the ligamentum nuchae. So this starts at the external occipital protuberance and goes all the way down to C7. This is why palpating the spinous process and the cervical spine is so challenging. So let's take a look at that guy. This is a huge, thick ligament. That's this entire thing running down from the external occipital protuberance all the way down, okay? So this area is pretty much, depending on how hard you push, almost impossible to really feel those spinous processes unless you really dig in, okay? So obviously this ligament is going to help keep that skull from falling forward, helps us keep that head up, okay? Helps with the traps and the other muscles for that capital extension and cervical extension and retraction. In lab, we'll look at doing, eventually, I don't know how much we'll get to this term, but next term, we'll definitely get into different stretches for muscles where we're actually getting our hands on, where we're working on this treatment component. So before working on the neck, we need to understand the vertebral artery and how it moves with the foramen. And this is going to innervate the posterior part of the brain. So we're going to do what's called a vertebral artery test. So I'm going to show you here a quick video, and we need to make sure we do this for every patient if we're going to work on their neck. So it's called the vertebral artery test. And actually, I'll show you a picture of the vertebral arteries first so you understand the purpose of the test. Let's find that picture. Oh, that's too bad. I thought I had it on here, so let's pull it up. Vertebral arteries. Here we go. So these are your vertebral arteries coming up through the foramen. So imagine if you really twist your cervical spine or extend it, you're going to pinch these areas off and reduce blood flow if you have any impingement along the way. So the test that you're going to see performed is going to be a test to make sure you have adequate blood flow so we don't stop the flow of blood to the head or the brain specifically while we are performing manual techniques to the cervical spine and skull. So here's the test.
Sitting if necessary. You have the patient relax. They're going to come back. They're going to ask the patient to keep their eyes open. They're going to come back in extension, rotation, and left side bending. And you ask the patient with their eyes open to count backwards from 20.
20, 19, 18, 17, 16, 15, 14, 13.
You're looking for any symptoms that may reflect vertebral artery symptoms such as facial numbness, nystagmus in the eyes, a change in the voice pattern.
So nystagmus in the eyes, we'll talk more about this as we move through the program, but the eyes start twitching back and forth?
All the above, or if there are any sympathetic responses with sweating. When I'm doing it in this direction, I'm showing the vertebral artery test with extension, left rotation, left side bending. I'm actually testing the right vertebral artery.
So we should see here that right vertebral artery is being stretched, and with that rotation, if there's any blockage, it's going to present with symptoms of nystagmus. So the eye movement, you might get dizzy, speech might get slurred. We need to check that. This guy has him counting for 20 seconds, 20, 30 seconds. Some people say more, but we need to give ample time to see if we're going to get any response. So we need to check that before doing other techniques. If at any point in time you're working with a patient and they start to get dizzy or have nystagmus when you're working on the neck, we don't try other techniques. We stop and then we talk to the PT. All right, back to the notes here. And that's pretty much it on the major part of the notes. Now we need to look at some arthrokinematics and the muscles and the biggest problem with the head neck area, which is the forward head posture. So again, if you haven't looked in more detail, I'm not going to spend a lot of time on this. The arthrokinematics of the facet joints and how they're oriented is going to tell you the motion that they do. So if we're looking here on the cervical spine, if you flex, then you're going to be having that kind of like almost anterior slide. But if you really look at the facet joints, they're oriented in kind of like a 45-degree fashion. Okay. So kind of like shingles on a roof. So that's how when you flex or protract, that's what the slide is. And then when you, so we're looking at flexion, we got our extension one here, then they're going to slide posterior or a little mix of posterior inferior. Again, having that kind of like 45-degree angle here. Okay. The one area we should be able to easily understand the arthrokinematics per the roll and the glide is at the sub-occipital joint. So that's when we go back to the atlas and C1. Here on the atlas, this is concave. So the skull is going to, unless you do something crazy and you're hanging by your head and you somehow fling your body back and forth, your head is always moving. So the convex, the skull, the occipital, the convex is always moving. So when you flex your skull, the roll is going to be anterior and the glide is going to be posterior. And then you switch that around for extension. And that's dealing with capital. Anything with the skull moving is capital extension or flexion. So that's old school arthrokinematics there. All right, let's talk about some of these muscles here so we are in good shape understanding that. So first thing we're going to look at is the sternocleidomastoid. And with this, you can see it's inserting on the mastoid process of the skull. And this is where the line of pull is so important to understand. If it's inserting there, and then either on the sternum or the clavicle, when it contracts, it's going to pull, if this, obviously this is the right side of the skull, it's going to pull the right side of the skull closer down towards the right side. So this does contralateral rotation. Okay, and you're going to need to stretch these things appropriately and to answer questions around the exam. You're going to need to know the motion. You always need to know the motions, but these rotations and neck muscles are always more challenging because there's a lot more going on. So contralateral rotation, a right side contraction of the sternocleidomastoid is going to turn your face to the left. Okay. Also, with our forward head posture, we'll see that when you are in a protracted state, this is going to be shortened. So your flexors, your SCM is going to be tight. So let's move over to another big muscle here. We're going to look at the levator scapula. And with that levator, whoops, lost my drawing. So it's going to be on the superior angle of the scapula, but notice here it inserts on the transverse processes and then comes down to the scapula. So the scapula is slightly posterior to those transverse processes, which means the pull is going to be to pull the transverse processes back posterior just a little bit. If that occurs, which way do you think the head is going to turn? And hopefully you said to the right. So this has ipsilateral rotation. Now, all of them do side bending, but they're all going to side bend to the same side because muscles pull. So obviously this is going to pull down into ipsilateral or the same side lateral flexion. The same with the SCM, the same with the traps, all of those. But the rotation is where it gets confusing. Also, the levator, since the spinous processes is anterior to the scapula, is going to help retract or extend the spine. There's a little difference to the retraction and extension, and then protraction and flexion. Okay, so start thinking about those when we get to that forward head posture. You're going to see how important it is that we understand those concepts. And then our third guy here that we really want to talk about is the trap, specifically the upper trap. Now, the upper trap is going to insert on the transverse process, the spinous process of the vertebrae. So if it goes from the spinous process down to the scapula, what's that pull going to do? That pull is going to pull the spinous process this way, which then is going to turn your face this way. So right side trap is going to give you left rotation, which means we have contralateral rotation. If you're still having difficulty with that, I can show you some stuff in lab, but it's because it inserts on the spinous process and it's going to pull the spinous process to the same side, thus the face has to go the other way. So those are three muscles we need to really be clear about. And now let's get to forward head posture, one of the biggest problems with the neck and head. And honestly, my two favorite things to treat are feet, because they're small and I can do a lot of manual work on those. And when you make people's feet feel better, they love you. And necks, because again, I can kind of control that head, I can work that neck. And the symptoms that arise from neck pain, from disabling headaches to all other types of things, TMJ, patients are going to love you. Those two areas, top and bottom, they're going to love you. And I really love treating them. And personally, I just had a lot of success with some very basic concepts, not even taking a bunch of continuing ed classes. So let's look at forward head posture. Forward head posture is going to be when you present with an, whoops, it's not supposed to be blue, I'm supposed to highlight that. Protraction of the scapula. So, or scapula, geez, protraction of the cervical spine. So as we can see, they say flexion here, but it's also protraction, okay? The head is forward, that's protraction. So the cervical spine is in flexion. So we also need to think about what's happening to the discs. Oops. What's happening to those? Same thing that's happening when we're dealing with the lumbar spine. So go back and review that if you need to. So we have that protraction. moving our head forward. What's that going to do to our muscles, right? How did we get to this spot? All of this stuff. Well, we need to get back into retraction. Classic treatment for this type of issue is called chin tucks. Literally trying to tuck that chin back. You're going to stretch the things that need stretched. You're going to help move things back where they need to be, okay? Getting into that proper postural alignment, getting back into some more retraction, okay? I know this looks excessive and you get that double chin, but you need that stretch and you need to get that head back with that forward posture. So with this, what muscles are tight? Well, let's get down here to the muscle picture. This might be a little confusing actually now that I think about it. So there's a good picture in your book that shows you muscles that could be tight or not. There's too many arrows going on there. I'm going to go back up and let's consider the muscles we have been working on. So if you're in this position, you are flexed and protracted. So the SCM is going to be tight in the front here because now our mastoid process is much closer than it was back here, okay? So the SCM is tight. And this is what's so often missed. Because the levator, it's going to be stretched quite a bit because the protraction, because it's going to help retract and extend the spine. The middle and most of the upper traps are going to be overstretched as well. But take a close look right here. And the skull here. This area where you have C1 and the skull. We actually have capital extension. The reason being is if you are protracted and flexed, your head is going to be down. So you're going to see me pop up in the video here. So if I have forward head posture, I look like this. But actually what would happen if I didn't extend my skull is I'd be looking at the ground. Well, I don't want to do that, so I have to extend the skull so that I can now look forward. And that's an often missed question and aspect of treatment is not stretching out the upper traps. That's why most people have had their levator stretched, but that's not what needs stretched. That needs other TLC. That doesn't need stretched. It's already getting stretched. We need to stretch the traps, specifically the upper traps, and really everything in the suboccipital area. You've probably heard of a suboccipital release. That's spelled incorrectly, but you get the idea. To help release these muscles that are super tight, keeping that skull up all day long because of the terrible posture. And that's what a lot of times leads to the headaches. Now, people may be feeling pain and tension in their upper traps or their traps on their shoulder, like, man, I just need that massage. Well, those muscles are working harder to keep that head up because you're so protracted. But also at the same time, that pain starts radiating down from that suboccipital area from those upper traps. So we need to do those chin tucks. We need to retract that neck, and we need to release that suboccipital area and stretch those upper traps. If you do that and you work on postural control and strengthening of the cervical spine in the correct positions, then you're going to have a lot of success. Now, this also mixes in with the rest of the spine we talked about. A lot of times if you have this forward head posture, you're also going to be very kyphotic in the thoracic spine. So if you're kyphotic, I want you to start thinking about what would that look like? Well, if we go up here, if we're kyphotic, more than likely I'm going to erase this since we've talked about this part. If you're kyphotic in the thoracic spine, your scapula is going to be protracted. So if the scapula is protracted, what's tight? The serratus. What is overstretched? Middle traps and rhomboids. Think about this. This scapula keeps moving forward. These rhomboids are going to get stretched. What do we need to strengthen? Rhomboids and middle traps. You got to get those scapula back. And maybe we need to do some stretching and soft tissue work to the serratus to try to loosen that up so when we strengthen, we can help get those scapulas back easier. You're also going to run into not, you know, a lot of people call it rounded shoulders, but what's happening is we have increased internal rotation. So now we need to work on stretching the internal rotators, doing doorway stretches, pec minor stretches, stretching all that out. And we need to strengthen our external rotators to help neutralize that shoulder. So that forward head posture is really a cause of a lot of things. And if you just treat the head right here, you're going to miss a lot because they're always going to go back to the same position. If they're kyphotic back here, then they're going to be protracted here. You're going to have extension of the skull. So if you just fix what you see, you're not looking down the chain, right? We need to work those rhomboids, middle traps. We need to work on those retractions, and we need to stretch out those capital extensors. You may have heard of the yoga block stretch, where you just lay back on a yoga block to help flex the capital, not the cervical spine, but the skull itself. So I'm going to pop up in this video again. If I am if I'm trying to do that yoga block stretch, this is what my head looks like. Super extended here. So if I'm on that yoga block and I'm laying down, I'm just trying to get my skull to flex. And that's something you should play around with, is just being able, can you just flex your skull and feel that stretch there? Can you retract back and flex the skull? That's the stretch you need, not protracted and flexed. Retract and flex that skull. That's what we need to stretch out for this. So there's a lot of stuff going on with that, but if you can get good at understanding that, you will be able to treat a lot of patients with neck pain and shoulder pain and upper back pain by just understanding a few of these basic concepts. Without even taking extra classes, just because you understand the basic kinesiology and biomechanics of the body. And in the next video, part 2, I'm going to talk about the jaw, and we'll look at like the TMJ.